Hi, welcome. This is really exciting for us. We do expect other people to roll in, should be a good number. But whoever is here, we just feel like this is going to be really valuable information for you. Thank you so much for jumping in and trying to learn something that's really helpful and positive. And I'm hoping that you'll actually be able to pass it on to others too, because anxiety and depression in a prenatal or postnatal state is not uncommon, and you are not alone. Just love having Bergen Nelson on our faculty. I'm the Director of Everyday Parenting Solutions, Susan Holt, and Bergen will be talking to you as soon as I give her a chance. So I'm going to turn it over to her and let her introduce herself, and thank you for being here.
Okay, hello, welcome. Can everybody hear me okay? Yes. I'm so glad you're here. Thank you so much for coming. And just like Susan said, hopefully something here will be helpful for you or somebody else. We want to make sure that everyone feels welcome to participate. So please raise your hand, type something in the chat. You can unmute yourself and we'd be happy to hear from you. This is a workshop. It should be interactive. Just wanted to introduce myself briefly. My name is Bergen Nelson. I am a pediatrician at the Children's Hospital of Richmond at VCU. And I have two little boys who are ages 6 and 8. They have tons of energy, as some of these ladies know. And being a mother has been one of the most humbling and wonderful experiences, but also one of the biggest challenges of my life. And so I wanted to share some of the things I've learned along the way in both my personal and professional experiences. And again, hopefully something will resonate with you and we want you to participate. So I'm going to go ahead and get started if everyone can hear me okay. Okay, great. So this is about Beyond the Blues. Thank you so much. We're so glad you're here. I just want to get a sense of who's here. And if you feel comfortable chatting, either typing in the chat or unmuting yourself and just telling us who you are and one thing you'd like to take away from tonight. So don't feel pressure to share, but if you feel comfortable, we'd love to hear from you. So I'll just give you guys a minute. Feel free to chat or unmute yourself as you are comfortable. What are you hoping to get away from tonight? We want to make sure we can target this to who's here. Anybody chatting? Okay, I will just move on then, but feel free to chime in whenever you feel like it. So this is a picture of my first baby Harper when he's probably about 2 weeks old here. He was a newborn. And I was very happy to be a mother. I was a pediatrician. I love children, and I was just really wanted to have a baby. But my personal life was a little complicated. I wasn't actually married at the time, and so when I decided to have a baby, it was like I had to figure out a few things. So I had a wonderful boyfriend at the time. He's now my husband and father of my 2 children. So it worked out in the end, but we didn't live together and we were not married. And so there was a little bit of complications just in terms of big changes in life. We moved in together and got married and had a baby, and I actually changed jobs and started a new job at that time. We moved into a new house. So it was like all these big life changes at once. And so, and I'll talk a little bit more about some of the other risk factors I might have had for experiencing postpartum depression. But looking back, just those sort of psychosocial changes by themselves were huge. But I think about what we all think of when we think about motherhood. And I think somebody once told me they thought of it as kind of a Mary Cassatt painting, like stillness, all of these wonderful moments where you're snuggling your baby and everything is warm and cozy and the baby is quiet and asleep and peaceful. And that's the image we have, right? And you also think about what you expect for yourself as a mom and the messages you've gotten from society about what makes a mother, what makes a good mother. And there's a lot of judgments that happen, right? What makes a good mother or what makes a bad mother. And so again, if any of you feel comfortable chiming in, just thinking about what your expectations were of motherhood, if you are a mother, what messages you've gotten about what makes a good or bad mother. For example, you know, I had this expectation that I would have this wonderful like baby shower and write thank you notes to all the people that came to my baby shower. And that didn't happen. I didn't get to write thank you notes to everybody. And part of my learning was that I had to let go of some of that perfectionism, right? Or that I would have a clean house all the time, or that I would make all my baby food from scratch, or all of these things that you just expect that you're going to do that don't happen, and you feel some amount of disappointment or guilt. And what we want to tell you during this workshop tonight is that you are not alone. That's really the main message tonight, is that this is the most common complication of pregnancy and childbirth. And so it happens to many, many women. And a lot of these things are swirling around in terms of our expectations and the messages we get. So again, if anyone wants to chime in on chat, I'm going to take a sip of my coffee. Hope you can get a cup of tea yourself and get comfortable. Has anyone said anything?
Yeah, the comment was, I thought it would be difficult, but not this difficult.
Hi, Julie. Yes. Great. Yeah. Yeah. It is. It is a whirlwind. So I'm going to just go on to, let's see. So the reality of motherhood is that it is difficult. It is a challenge. And so when I expected stillness and calm and quiet as a mother, and what I got was a sea of motion, constant motion. And Susan Holt here knows my children, and they came over for dinner the other night and said, they are just running around. It's a lot of kinetic energy. And so you can see this picture. My youngest Sawyer was about almost 1 year old there, and we couldn't even get a picture without him being blurred because he's so fast. He just was crawling like 60 miles an hour, and you know, crawling on top of his brother. Harper was trying to read a book there, and they were just all over the place, and toys were everywhere. And the reality is that it's kind of a perfect storm. So when you have a baby, you go through a lot of big changes. Your body goes through a major physical stress. The process of giving birth is a major physical stress. You are almost by definition sleep deprived from the beginning, because most people go through a long labor, and then babies wake up every couple of hours. They need to be fed every couple of hours. They need to have diapers changed every couple of hours. They cry. Babies cry, babies poop. They're not always sleeping like little angels. Sometimes breastfeeding can be challenging. I just remember feeling my nipples being sore and cracked and bleeding, and that's hard, you know, and you have these expectations. You want to breastfeed, and when a baby needs a drop of formula, you feel like a failure. And then again, you're getting a lot of opinions. So, you know, you have your parents, your mother, your mother-in-law, your friends, your sister, whoever is telling you their opinion about motherhood. And so all of these things come together, and it's like a perfect storm, right? When you're sleep deprived and stressed and in pain, and you have this huge change in your life, all those things create the conditions for depression and anxiety. It's understandable. It's amazing that more people don't get depressed and anxious, right? So just remember, this is understandable. You're not alone, and it does get better. So we're going to talk about some of the ways that we can get better. So just a little word about terminology. We wanted to talk about beyond the blues and thinking about the word perinatal. Perinatal means during, oops, sorry. I have a touch screen here. During pregnancy or up to 1 year postpartum. So that can be, you know, 9 months of pregnancy plus a year postpartum. That's almost 2 years of time that is considered perinatal. So it's not just postpartum. And it's not just depression. That a lot of depression and these mood and anxiety disorders look more like anxiety in the postpartum period. And I talk a lot with moms about how being a little bit anxious can be adaptive. It's probably one of the reasons that our species has survived. We worry about our babies, right? We need to do these things to take care of them, to keep them alive. But when these go onto overdrive, that's when we get in trouble. So it's not just postpartum, it's not just depression. And so we talk about perinatal mood and anxiety disorders, or PMADS. And together, this group of conditions makes up the #1 most common complication of pregnancy and childbirth. So thinking about what are the baby blues? You all have heard about that. Baby blues happens in the first couple of weeks after a baby is born, 2 to 4 weeks. And that is that emotional roller coaster, right? The highs and the lows. You cry at the drop of a hat. You feel sleep deprived and emotional, just raw and vulnerable. That happens to most women right after pregnancy, again, because of that perfect storm of sleep deprivation and physical stress and a big life change. So that is really common. That almost happens to everybody. Up to 80% of women experience the baby blues. What makes a difference? When does it become something more than that? Is when it goes into a little bit longer. So if it lasts more than 2 to 4 weeks into your postpartum period, if it is severe, and if it is affecting your function, so your ability to take care of yourself and your baby and feel comfortable and like you're coping. So that's important. And so depression is the most common symptom, and we've all probably heard about the symptoms of depression: sadness, guilt, sometimes trouble sleeping, sometimes loss of appetite. That happens during pregnancy in about 10% of women, which actually makes it the #1 most common complication of pregnancy. And then 15% postpartum, so it increases in the postpartum period. And people who have a baseline history of depression themselves are more likely, that postpartum period, again, is a vulnerable time. So they're more likely to get the postpartum depression. And like I said, a lot of the PMADS, or postpartum depression, quote unquote, the reason we don't call it postpartum depression is that it actually looks more like anxiety in a lot of situations. And we'll talk about screening tools and identification, but that anxiety component in the postpartum is a little bit more specific to postpartum. And again, I think that's probably evolution in part. It's like, we want to take care of our babies. We want to make sure everything's right. We want to make sure everything's clean. We're worried, is the baby getting enough? Is the baby okay? Who's taking care of the baby? And so that anxiety is really predominant in the postpartum. And then these more rare conditions, including postpartum or perinatal obsessive compulsive disorder and post-traumatic stress disorder, are really just those conditions in the postpartum or perinatal period, and they're less common, but they still happen a fair amount. So OCD in 3 to 5% of women in the perinatal period, so that's not insignificant. And that can look like compulsive cleaning of things, doing rituals, having a lot of fear and obsessions about certain things happening. And if they don't happen, then you feel really anxious about it. And then PTSD, really happens after a trauma. And that can happen because of birth trauma and complications from the delivery, the pregnancy or delivery itself. It can also happen from past trauma outside of the pregnancy, things like sexual abuse or physical abuse, some traumatic event that a woman has experienced, and then sometimes the experience of delivery and early baby carrying can trigger some of those past memories, and women can have flashbacks. Bipolar is the swing between a manic episode and a depressive episode. So women who are manic may stay up for hours and hours and hours and not be able to sleep, and have lots of energy, lots of goal-directed activity like cleaning and writing those thank you notes instead of sleeping when you should be sleeping, cleaning the house. And then very, very rare is this perinatal or postpartum psychosis, which is very extremely rare, 0.1% of all women. So that's 1 in about 1,000 births. And that is the most concerning, and that's really a psychiatric emergency. Psychosis is when you're having thoughts that you actually think are real and you have a break with reality. So we'll talk more about this, but you know, in normal anxiety, depression, we all have intrusive thoughts, right? We have thoughts, scary thoughts, but you know that those are upsetting and those are not real, and you can differentiate between reality. And you might have anxiety about doing things like hurting your baby, but you know you're not actually going to do it. And women with depression, anxiety typically do not ever hurt their babies. They're more likely to hurt themselves than the babies. So actually suicide is the most common complication, the most scary complication. With psychosis, it's a little different. That's a true emergency when there are thoughts that actually you don't recognize as foreign or outside of yourself. So they're not real, but you think they are real. And in that situation, which is extremely rare, then this is the kind of situation when women sometimes will hurt their children. And so when you hear about things like women hurting babies and hurting their children, that's usually from psychosis. And that's, again, very rare. So that's not the most common. You're much more likely to have the garden variety anxiety disorders. Okay, I hope that's clear. If anyone has a question, again, please raise your hand, jump in, chat, unmute yourself. Okay, so again, the difference between the blues and the anxiety and depression disorders are really about duration, severity, and impairment. So can you function? Can you take care of yourself? Can you do the things you need to do in your daily life? Can you take care of your baby? Are you coping? All right. Thinking a little about fathers, there's a picture of my father when I was a baby, me as a little baby, but so fathers can also get depressed and anxious, and partners and non-gestational parents like adoptive parents or same-sex parents, and anybody who's there having that same life stress of having a newborn in the house, it's possible for them also to get depressed and anxious, and that's probably much less, much less recognized because people are not routinely screening partners and fathers, and partners and fathers are not always empowered to speak up and recognize that they might have these symptoms. So it's important to know that this can happen, and they also need support. Partners and other parents can be a source of great support for moms who have anxiety, depression. They can also be a source of stress, right? So things like marital discord and things that, if you disagree about parenting or you're disagreeing about really anything in life together, it can be a source of stress. And so working those issues out can be really important. And then importantly, I do research in early childhood development, and it has been shown that when moms are depressed, that there can be some consequences for children and early childhood development and behavior, but partners, fathers, other caregivers in that child's life can actually serve as a buffer, an important buffer. So that positive interaction with a child and other caregivers in their world can be very healing and therapeutic and positive, even if moms are suffering from depression or anxiety. Okay. I'm just going to move this back, sorry. All right. But those partners also need help. So thinking a little bit about risk factors, it's like this Venn diagram. So you'll see some overlap, but there's biologic things that can be risk factors, psychological risk factors, and also social risk factors. And I mentioned a few of those risk factors in myself, but we'll go through some of them now. So biologic risks are really anyone with a personal or family history of depression or anxiety. So that's kind of a genetic and biologic condition. So I personally had premenstrual dysphoria growing up, like clockwork. Every time I would have a menstrual period, I would get sort of tearful and irritable and anxious around just like for a day, and then things would get better, and it was just became like clockwork. And so I know that my mood is very sensitive to hormonal changes, and I probably could have predicted that when those hormones crash at the end of pregnancy and at the beginning of newborn life, that I might have experienced some of these things. Any kind of medical illness in a mom, things like diabetes or thyroid dysfunction or anemia, so things that might be sapping your energy anyway, then you have this added stress of pregnancy and delivery. Birth complications, so when things don't go completely right, that can be hard when you have to have something like an unexpected C-section, which I ended up having. I had a condition of a very severe preeclampsia condition called HELLP syndrome, which is HELLP, hemolysis, elevated liver enzymes, and low platelets. My mother used to joke, she's like, focus on the hell, the HELL. It was really hard. And just to give you a sense, like a normal platelet levels, like in the 200 or 300s, and mine dropped down to 20,000. So it was 20 instead of 200. And they were worried that that I could have a bleed, or my liver enzymes normally in the 20s went up to 1,000. So the anesthesiologist working with me during my C-section made comments like, some women have liver failure and die from this condition. And that certainly didn't help myself or my loved ones with the stress. So those kind of complications, either with the mom or the baby, can certainly be an additional biologic stressor. And then other moms who've had trouble getting pregnant and had fertility treatments, that can be another biologic risk factor. Any questions about that? So we'll move on to the psychologic risk factors. So just thinking about how big a life change this is of becoming a mother. It's a huge change in your identity. And that just psychically is a big, big adjustment. And it changes your family life. So having any kind of stress at home, discord with your family or your spouse, your partner, can be a stressor. I have to move my thing so I can see. Any history of trauma, and having unresolved early losses. So moms who have had like lost a parent or a sibling or another child can certainly be at risk. Having a complex history with one's own mother, and then thinking about your own identity as a mother can be, that's the whole analytic discussion of its own, but that can certainly be a risk factor. Having some ambivalence about becoming a mother. And then again, birth complications. Birth complications might be like in the center of this Venn diagram. It comes up on all of the different bio, psycho, and social. But having a baby that's in the NICU, for example, can be very stressful. Even if the stress is not on the mom's body anymore, it's a psychologic risk, that fear about a sick baby. Okay, so keep going then, social. Okay, thank you. Thinking about social risks, we all need support. When we are parents, we all need support, and not having that support is a risk, being isolated. Having financial or stressors or basic kinds of needs, having homelessness, food insecurity, certainly those things do not help in any situation. So having all of this perfect storm we just discussed, plus those basic needs, is certainly a major stressor. Again, not having enough support. So single moms are at higher risk, teen moms, immigrant moms. Again, I think all of this has to do with that support, not having as much support around that baby and that mom. Moms in the military who've had to move around to different places and might not be as integrated into every community that they've been into. And again, birth complications, the social aspects of that. So we've talked about risk factors, and hopefully people aren't too depressed. So we want to get into some of the more hopeful parts of this. Oh, finally having a colicky baby. So I kind of specialize in colic. I'm a pediatrician. Babies cry, And sometimes babies cry just because they're babies, and it's nothing that you did wrong. You're not doing anything wrong. And sometimes just soothing the baby can work wonders. Some babies cry more than others. But I think probably my low point, I had a baby at the end of October, and around Thanksgiving, my baby was about 6 weeks old. And 6 to 8 weeks is the peak crying period. And I know that. And I was a pediatrician at the time, but my baby at the end of Thanksgiving dinner was crying and crying and crying. And there was nothing I could do to stop him crying. And I felt like a total failure. And that was kind of the beginning of a low point for me. And unfortunately, it can be a vicious cycle, right? If moms are anxious or depressed, then it's harder for them to soothe their baby. So again, having another caregiver that can help do some of that soothing is very helpful. All right, so now thinking about babies and kids, this is my area of expertise, is early childhood development and behavior, but we know that these conditions for moms do affect the whole family. So it's not just common, it's really consequential as well. It can cause a lot of stress. It can result in insecure attachments and developmental behavioral issues. And then sometimes it creates a risk for not necessarily following guidelines. So like safe sleep guidelines and breastfeeding recommendations and things like that. Moms who have these conditions may not follow some of those guidelines. But again, you know, I don't want to say any of this to upset or trigger you, but just to say that this is important and we need to talk about it, because it's important. It's consequential, not just for mothers, but for the whole family. So what are things we can do to help? I want to spend a lot of time here. So one way that we can help is by screening and by identifying these symptoms early on and getting families, moms and kids and families connected to support. So I'll talk a little bit about some common specific screening tools that we use, but really, if any of you are in the position where you're offering support to somebody directly who has talked about feeling anxious or depressed in the perinatal period, the 3 kind of postpartum support international messages that are universal messages that we all can share with each other are: you are not alone, you are not to blame, it's not your fault. And with the right help and support, you will get well. It does get better. So those 3 messages I talk about all the time, and I remind myself, and just, you know, even before you start thinking about things like therapies or medications or support groups, just hearing those messages can be very helpful. And I'm now like 8 years outside of this experience, and so I can talk about it, and telling my story is therapeutic and helping other women is therapeutic, but I know that being closer to it is harder. So wherever you are in this journey, know that it does get better and there is support out there. If you're here in Virginia, Postpartum Support Virginia has wonderful resource directories. So they have a resource directory you can put in your zip code and find therapists that take different kinds of insurance. You can find support groups. You can find information on self-care. We'll talk about their pathways to healing. But they are a wonderful website, and that website is shared on your notes page. Postpartum Support International has hotlines that you can call if you're ever in a crisis or you need to give somebody a number to call in case they're at a crisis level. They can, that and the suicide prevention hotline are really important numbers to have. And then thinking about these different groups, so the Centers for Disease Control and Prevention has data on national prevalence. Again, it's up to 20% of pregnant and parenting moms have perinatal or PMADS, perinatal mood and anxiety disorders. So some of that data nationally is held there at the CDC. The American College of Obstetricians and Gynecologists, or ACOG, they have a lot of recommendations about caring for pregnant women with mood and anxiety disorders. And then the American Academy of Pediatrics actually recommends that we screen in pediatrics for maternal issues. So even though the mom is the one getting the screening, we can bill for it. We can talk about it in our notes. The Postpartum Stress Center has a wonderful information sheet about postpartum OCD. So if that's a specific issue. And then the Blue Dot Project has a great website with people telling their stories. So it's a lot of other moms who have gone through it, and you can hear some of those beautiful stories about healing, hope and healing. Okay, so getting a little bit into screening. Here are some of the screening tools we use, and I'll tell you the ones we use most often in sort of primary care clinical settings is the Edinburgh Postnatal Depression Scale, and also the Patient Health Questionnaire 9, the PHQ-9. And you can see that those are the two shortest ones. So those are the ones that you can do in less than 5 minutes. The little bit longer ones might be used more for more kind of clinical, if you're a psychologist and you have a longer visit, like the Beck Depression Inventory, take a little bit longer, but they have a little bit more information. And then things like the Center for Epidemiologic Studies Depression Scale, or Ptsd, I've actually used in research studies. So that takes a longer time, but it gives you, again, more information, and you might see it in some of the research studies around perinatal mood and anxiety disorders. So this is an example of the Edinburgh. It has 10 questions, and you can see that each one has 4 options, and so those you can score from 0 to 3. So each one has a 0, 1, 2, or 3, depending on the level. So the lowest score you can get on this is a 0 if you put zeros on everything. Some of them are reverse coded, so don't worry about the order. The ones that have a little asterisk are reverse coded. And then the highest score is a 30. So if you got 10 threes on everything. So we consider anything higher than a 10 to be positive. That's a concern for elevated symptoms of depression or anxiety. And any score on other than a 0, other than a never on question 10, so that's a thought of self-harm. So even if you score 0 on everything else, if you have even a hardly ever on the thought of harming yourself, we need to do some additional things. So then we need to assess and make sure that there's not an active plan, not an active suicidal ideation happening. And asking just so you know, if you're a provider or mom, asking about suicide does not cause people to make suicide attempts. It's very important to recognize that just people are thinking these things and we're just uncovering it and making it known. We don't put ideas in people's heads. This is the PHQ-9, which is a standard depression scale, and you score this basically a 0 to 4. I don't know if you can see that. Am I covering it with my thing? You can see, okay, good. So a 0 to 4 is really minimal symptoms, and then up to mild, moderate, severe depression. Again, it's a 0, 1, 2, or 3 on all 9 questions. And so a 27 is the highest here. And you might have seen something called the PHQ-2, which is really just the first 2 questions of the PHQ-9, not having interest or pleasure in doing things, feeling down, depressed, hopeless. You'll notice that these symptoms all really ask about mood, and it's really a depression screen. It doesn't get at the anxiety as much. And so the Edinburgh is kind of a preferred tool because it asks those questions about anxiety, and anxiety is more specific to the postpartum period. So some pathways to wellness. Now, I'd like everyone to sit back and just take some deep breaths. This is what I love to do. Just take 3 deep breaths right now. Now, I don't know about you, but doing that just helps calm my nervous system if I'm giving a presentation or I'm about to do something. And I think it's helpful for all of us when we have raw nerves to just take a moment, do some of that deep belly breathing. So I wanted to share, and I'll just jump ahead a little bit because this is the pathway to wellness that comes from Postpartum Support Virginia. So it's available on their website, but it talks about the different modalities of treatment. So self-care, social support, talk therapy, and medication. And so I'll just go back to that. But really the underlying key to all of this is not to feel ashamed to ask for help. So we don't want to have a world where these things are so stigmatized that people don't ask for help. If you ask for help, then help will come. And you can do some of that for yourself, and you can get the people around you to help you. So self-care, I just have it on here, but it's a huge thing, and it might look different for different women at different times. It might mean sleeping, or taking a walk, or taking a shower, making sure you get a good meal. So for me, when I had my second son, I said, people can only come visit if they bring me food.
Wow.
Nobody can come without food, and I'm only going to have one person visit in a day. The mistake I made the first time was having somebody at breakfast, lunch, and dinner and having to serve people. We were having to get people meals, breakfast, lunch, and dinner, so that they could hold the baby. And I said, no, I'll hold the baby. You feed me. And that was much better. And that I had to be empowered to do that. And I encourage you to empower yourself to get other people to do the cooking and the cleaning, and to you just take care of the baby and yourself, and let other people feed you. Let other people hold your baby so that you can take a nap or a shower or a walk or go out with a girlfriend for lunch, whatever you need to do. Okay, so all of that self-care is really important, and it takes a certain amount of assertiveness to work out with your partners, your friends, your family, what you need. And then social support. So we have support groups, and I'll talk a little bit about how we can find them. But support groups are very helpful. We have one at VCU. There are all over the Richmond area and Virginia. You can find them on the Postpartum Support Virginia website. And that can be very helpful. And then certainly do not ever be afraid to ask for professional help. So a combination of therapy and medication and self-care and social support may be the best answer. You do all of the above. And that's really what I did when I was taking care of myself. It was like the kitchen sink approach to prevention of postpartum depression. I did everything. I had therapy, I took medication, I got hypnosis, I got Reiki, I made people come with food and feed me, I talked about my story. So I did all the things. I did yoga, I got massages every month. And that made for a totally different experience the second time around, because I was assertive and asked for what I needed. Please know that medication can be safe and effective while you're pregnant, while you're postpartum, while you're breastfeeding. So there are medications like sertraline or Zoloft that has very, very, very low levels that get into breast milk. So if you go to a specialist that knows about how to prescribe to pregnant and nursing mothers, they can guide you to the safest and most effective medication. So just because you're pregnant, just because you're breastfeeding, certainly does not mean that you should not be taking medications. You need to take care of yourself first, and there are safe options. Okay, again, this is the Pathway to Wellness by Postpartum Support Virginia. I encourage you to download it, print it out, put it on your fridge. There are support groups. So this is our support group at VCU, Getting Better Together. We have dinner and childcare, and it's every other Tuesday at the Children's Pavilion on Broad Street. And then again, these core messages that you are not alone, you are not to blame, and with help, you will be well. Some helpful resources in terms of books. My favorite one is dropping the baby and other scary thoughts. It's really amazing about how common that thought is, right? That fearful thought. It's not unusual or abnormal to be thinking some of these thoughts, but how you cope with them and what you do about them is what really matters. Okay, things like this isn't what I expected. And these websites that hopefully have some helpful information for you. Okay. So that is the end of the slides, and I wanted to leave a little bit of time. That's Harper. He survived my postpartum depression. He's now 8 years old, and he's a second grader and doing just fine. There he is when he was about, I don't know, almost 1, waving goodbye to somebody in a restaurant, or hello. Please, I'd love to hear your thoughts, your experiences. We really want to hear from you. So again, if you want to unmute yourself, if you feel comfortable, if you have any questions, if you want to type something in the chat box.
You mentioned hypnosis and Reiki. How does that help?
Yeah. So this has been part of my journey, but I actually found a doula for my second pregnancy. It was interesting. I was pregnant with my second one, having experienced postpartum depression after my first, and I was part of a group because I'm a pediatrician of this task force in Los Angeles, the postpartum maternal mental health task force. And so the director we were just having a work meeting, and I was telling her about some of my personal experiences, and she said, this is really preventable. If you can recognize these symptoms early, you can prevent it happening again. And so I just went after all the different healing modalities, and I had a good friend who's a doula, and she introduced me to the doula who was going to be my my support partner doula during my second son's birth. And she is a certified hypnotherapist. And so she did hypnotherapy for me when I was pregnant, when I was in labor, and when I was postpartum. And it was very helpful because it just like taking deep breaths, except it gets you into a much deeper relaxation state. It puts you into deep relaxation. So it just kind of calms those ragged nerves and helps elicit the relaxation response. And I think that by itself was very, very healing. It also can activate your subconscious in a way that sometimes those conscious thoughts don't let you do when you're having those kind of perseverative thoughts. You need to sort of tap into your subconscious, and so it gets deep into that. I just found that really relaxing and wonderful and healing. And then that same woman who's a hypnotherapist is a Reiki master, and so Reiki is a little bit more of a spiritual kind of modality, but it's basically saying that we all have access to divine energy. And so if you think about energy coming through you from God, the universe, whatever it is that you believe, that it comes through you and out of you. And so if you just take your hands and kind of put them close together, you feel heat coming off your body. You can feel that energy. And if you can learn how to channel it and target it. So I became an attuned Reiki myself, got some treatments from this hypnotherapist, and she attuned me so that I was able to do this for myself. So I can give myself Reiki energy. I can give my children Reiki energy. I give my husband Reiki energy. And I just try to help calm the chaos of my house. And I think, like hypnotherapy, it elicits a relaxation response. And you feel cared for when you're touched by somebody else. There's some serotonin. We know that physical touch is helpful. So relaxation, physical touch, being cared for by somebody else are all very healing. Good question. Anything else?
are breastfeeding moms more at risk?
So actually, so like I did say, breastfeeding is stressful, but the literature does show actually that breastfeeding is therapeutic. It can help prevent some of these conditions, maybe because of the ongoing oxytocin and hormones that are happening because of breastfeeding, because of that bonding with the baby, because you feel empowered and you're feeding the baby and the baby is growing and developing, and you can feel proud that you did that. For whatever biopsychosocial reasons are out there, breastfeeding tends to be helpful. I will say in the first week or so, breastfeeding can be stressful. And so, you know, we used to, the AAP and everybody used to say breast is best, and it is. So there's lots of benefits to breast milk, but we've switched it now to say fed is best. So the bottom line is feed the baby whatever way works for you in your life, and don't feel guilty or don't feel shame about it. Don't let anyone tell you. If you got to make a decision about what works best in your world, your body, your life. But in general, breastfeeding can be actually therapeutic.
So I was just wondering too, Bergen, this has been so informative, and you have such a beautiful way of explaining it all and encouraging all of us. You mentioned that specialists would be the people to go to because they would understand how to prescribe the particular kind of medications needed for that, for being pre and postnatal. Are you a specialist, or would somebody come to you to get a specialist name? What's a specialist?
Yeah, that's a very good question. I am not a specialist. I'm a general pediatrician. I do screening, and I make referrals to perinatal psychiatrists or therapists. So somebody that could prescribe is a psychiatrist who has, and there are psychiatrists with a perinatal specialization. So for example, at the VCU high risk OB clinic, there is a perinatal psychiatrist that's embedded in that clinic. And she has some expertise in how to manage medications in pregnant and postpartum women. So any psychiatrist, or, you know, but you don't, for things like Zoloft and things, you can go to a primary care physician, so it would be the mother's primary care physician. It's possible. I mean, I think that the choice between seeing a specialist and getting no care, it's better to get care from anyone that can prescribe it. I think it is best if there's somebody in your area that has that perinatal specialty. A perinatal psychiatrist would be best, but a primary care doctor, a family doctor, a primary care internist can also prescribe frontline antidepressants as long as it's not complicated. Is there another chat?
Nothing in the chat, but I guess if you could go into, oh, well, I can be heard, believe me. If you can maybe give us some additional input, if you believe that you are someone's support system and you are that first line identifier, are there phrases that we should be using? Are there things that we can do to help make them continue to feel comfortable with taking these steps?
Yeah, so that's a great question. And like I said, those phrases that come from Postpartum Support International, you are not alone, you are not to blame, with help you will be well. I think those are really important messages, no matter where you are. So if you are a caregiver, if you are a family coach, or you know, anybody in the continuum of care for this family can give those messages. I teach this to my medical students and residents. Sometimes they feel helpless, you know, when these things come. A lot of people can feel helpless, but sort of those very sort of just showing an empathetic response initially can be helpful. And then connecting, I think connecting to real valuable resources. So the information, the websites, the books, therapists in the area, specialty psychiatrists, therapists, support groups, all of those kinds of things. And then connecting to things like that Pathway to Wellness from Postpartum Support Virginia that goes through concrete strategies about like how to get a few more hours sleep. Like literally, how can you negotiate with your partner shifts to take at night so that you both get a good chunk of uninterrupted sleep? That's really important. So all of those things can be helpful and happen in very relatively short amount of time.
We have about 1 more minute if we have any more chats. And then we'll have 5 minutes to do the eval.
Okay, so just to make sure that you hear, we have about 1 more minute. If anyone has a question they'd like to put in the chat.
I just want to say thank you again for coming.
I just have one quick thing. You said, can she hear me?
Yeah.
You said Getting Better Together was a support network. How do you get into that? Did you put a resource for that? Is that through VCU?
Yeah, so
This is like a
that's,
simple way to kind of just
Yes.
be together.
yeah, so that is the VCU Moms webpage.
Okay.
I'm unmuted there. I'm unmuted. Thank you. The VCU Moms webpage. If you just Google Getting Better Together VCU, it'll show you the dates. It's open to the public. It's free. You can get free parking. So it has the logistical information. You can register, which is helpful. Then they just know how much food to order and how much childcare to prepare for. But that is at VCU, but they have support groups at Bon Secours, they have support group at Johnston Willis. So again, that Postpartum Support Virginia website, you can locate support groups that are closest to you and that have scheduled on different days of the week and different times. Some of them are during the day, during the week, some of them are on Saturdays. So whatever's most convenient for what you need. Ours happens to be on Tuesday night at the Children's Pavilion. But it's open to everybody.